Hi, this is the first of a series of presentations that I'll be discussing the principles of the patient interview or subjective examination. And I'm going to be covering in today's presentation what I describe as skilled communication in our patient interview, which is necessary in order to optimize thoroughness and accuracy of information gained, patient satisfaction with us, and our clinical outcome. I'll then briefly highlight the different components or sections of the patient interview. And lastly, I will begin to talk about our introduction to the patient, our clarification of their main problem or complaint, and what we call setting the scene. So the components of the patient interview and the information that's sought is directly related to the overall purpose of physiotherapy clinical reasoning as presented in the clinical reasoning theory sessions. So you'll remember that I defined clinical reasoning as a process of inquiry and analysis carried out by the physiotherapist in collaboration with the patient. And I emphasize that our clinical reasoning is about human judgment and the processes for reaching those judgments. Now, within our biopsychosocial approach to practice and to clinical reasoning, we said that the purpose is to understand the patient as a person, their context, their clinical problem, in order to guide our evidence-based or informed practice. And this is where we see the link to the patient interview or subjective examination, because in order to fulfill that purpose, we need information about each of those broad categories. We need a lot of information about the patient as a person, their personal circumstances, and we need a lot of information about the clinical problem. And then we engage in our hypothetico-deductive process. Once we get the information, we have to judge what's potentially relevant. We have to interpret it, synthesize it from that information to generate hypotheses. And I've highlighted the different categories of hypotheses or clinical judgments that are important. And then we need to be prepared to test those hypotheses and then modify them when necessary. And collectively, excuse me, that gives us the ability to make a fast first impression about the person and their problem, but we will always be using the slower analytical deliberation in our reasoning. I also presented this World Health Organization diagram, and I want to also link this to the patient interview. So when I presented this, I talked about the boxes across the middle being the clinical presentation. So the patient's impairments in body functions and structures, their activity capabilities and restrictions, and then how that translates and influences their ability to participate in everyday activities at work, home, sport, and leisure. But importantly, that's going to be influenced by a combination of the biological factors at the top, so the pathology of the disease, the clinical syndrome, for example, but also the contextual factors highlighted in the boxes at the bottom. So the personal factors that incorporate the patient's understanding, beliefs, coping strategy, and others, and the environmental factors, both the physical and the social environment. So you can see what this highlights is the scope of knowledge we need to have as physiotherapists, the scope of examination skills, the scope of clinical reasoning, but also what we need to have in our patient interview. Our interview has to be thorough to understand the person and their problem as demonstrated across this model. I want to highlight today the importance of skilled communication in your patient interview in order to optimize thoroughness, accuracy of information gained, patient satisfaction with you as a therapist, and ultimately the clinical outcome. Now, to emphasize the importance of skilled communication, I'll discuss 4 key aspects of the patient interview and the associated communication strategies that we would like you to develop. So the column on the left highlights these 4 aspects that we call invest in the beginning, elicit the patient's perspective, demonstrate empathy, and invest in the end. And then you can see on the right the skilled communication strategies associated with each of those aspects. And I'd like to go through these individually. So with the invest in the beginning, and this refers to the very beginning of our examination and then how that continues on. And one of the most important things that we need to have as a communication strategy is the ability to develop rapport with our patients. Now, there are numerous ways to establish rapport, but central is conveying interest in the person, not just their problem. So we don't think of them as just a back pain or my knee patient. We think of them as a person with this particular problem. Empathy, or being able to imagine what your patient is experiencing with their problem, and then developing the skill to convey your empathy to the patient, is another important way of establishing rapport. And validation of concerns, which is your ability to give the patient the opportunity to voice any concerns they have, not just their main complaint, but any other concerns they have related to their problem. And there are numerous times through the subjective examination where you can do this, and I'll be highlighting this in my different presentations. Now, I stated that a key to establishing rapport is conveying interest in the patient as a person, not just their problem. That is, don't think of them just as a knee patient. Think of them as a person with knee pain. And your interest is conveyed when you give the patient the opportunity to tell their story. We do this when we explore the effects the problem is having on their life, in the behavior of symptoms, and through the history. And also when we explore their personal perspectives, for example, what they think is causing or contributing to their problem. The second area within invest in the beginning is setting the scene for what's to come. So, for example, brief explanations that the examination that we'll be conducting today will be followed by discussion of your analysis and your recommendation, and also discussion of their preferences and their goals. So the patient knows what's going to happen. And you may break that down and give the details of, we're starting with a discussion about your problem. And I'll be asking you many questions about that. And then we'll move into what we call the physical examination. And then from there, we'll go into treatment. Don't assume that the patient's understanding of the different lines of questioning and physical assessments is necessarily there. And that is that patients, particularly if they haven't seen a physiotherapist before, often don't know what to expect, and they don't fully appreciate the line of questioning. Misunderstandings are very common between health professionals and their patients, and unfortunately, they often lead to dissatisfied patients and even sometimes legal issues. And they can be minimized by informing the patient through the examination with simply brief explanations of each component, along with an upfront invitation to ask questions at any time. So it could be as simple as, now I'm going to be asking you questions about exactly what you feel and where you feel it. So I'm going to map out on this body chart I have of each of the symptoms you're experiencing and where they are. This will help me understand your problem. And I'll do this very, very brief explanation as I move into each section of my subjective examination. And the third part of invest in the beginning is eliciting the full spectrum of the patient's concerns. Now, patients' participation really shouldn't just be simply to answer questions. We don't want them to just be passive in the subjective examination. What we want is for them to share what information they believe is important about their problem. We, of course, will ask them many questions that they'll be answering, but we need to give them opportunities to share what they think. And we need to validate the information that we're getting from them and how we're synthesizing that as accurate. And what I mean by that is, for example, if I have finished the behavior of symptoms and I've got an overview of their aggravating, their easing factors, their 24-hour pattern, I may say something like, let me just see if I've got that right, and give them a brief summary of the key points. And what I'm doing is I'm validating that I've listened to them, and this is what I've taken from it, and it gives them the opportunity to say yes, or perhaps to correct me and add something to the overall picture. Now, clarification of patients' additional concerns besides the main problem is also part of getting the full spectrum of patients' concerns. In other words, we don't want to limit our assessment and analysis just to the main complaint or just to what the doctor said was the main problem. So we do that by asking the patient about any other areas that they're having problem, and we have a specific process of screening where we screen for other symptoms, we screen for other aggravating factors, we screen for psychosocial issues, so that we pick up on all concerns that the patient has, and we try to look for the relationship of those concerns to their main problem. We get a complete picture. Okay, now the different components of the patient interview are outlined in this slide. So initially there's our introduction of ourselves to the patient and establishing what their main complaint or problem is and setting the scene. And I'll come back to that in a moment and elaborate. But the other sections of our subjective examination include what we call the personal profile or social history. You can get this at different times, but it's often useful to get it very early so you understand a little bit about the context, in other words, the patient's circumstances, before you get the details of the problem itself. Then we have the area and description of symptoms. And this is something that typically we achieve through using a body chart where we ask them where they feel each of the symptoms they experience, and we try to map it out in some detail. And then with that, we make sure we're clear on how they describe it, including the words they use and the depth that they feel each symptom, and even the relationship between different symptoms. And this all is mapped out on our body chart. Then we go through detailed questioning about the behavior of symptoms, and that includes aggravating and easing factors, as well as the 24-hour pattern. We have a section that is devoted to questions that are linked to precautions and contraindications. So this includes our general health screening, but other special questions that are related to safety. We have a section on the history and past history, where we explore in detail the mechanism of onset and, importantly, the progression of the problem. And then we have this important area we call psychosocial screening. And of course, as I've mentioned before, psychosocial issues can come out at any point. And so the patient may volunteer, even if we haven't asked about them. But if that information has not been volunteered or spontaneously offered to us, we need to have a very clear framework about what questions to screen, what areas to screen of psychosocial factors, and where we're going to have that in our examination. And then lastly, we need to be clear, and a section of our examination should cover what are the patient's goals, what are their expectations, and what are their preferences. So the last thing I want to talk about today is our introduction when we first see a patient, our establishment of their main problem or complaint, and what we call setting the scene. Now, by introduction, I mean when you first meet a patient, trying to develop this rapport and help the patient be at ease just by how you introduce yourself. So for example, I would typically say, hello, I'm Mark Jones. I'm your physiotherapist today. Please call me Mark. And then I'll clarify, how would you like to be addressed? I don't assume what name they want to go by. I ask them that. It's a simple thing, but it shows respect, and it starts to build this therapeutic alliance or relationship and rapport. Establishing the main problem should happen right at the beginning of the subjective examination or patient interview. In other words, we're going to ask the patient specifically, what is the main complaint they have? What has brought them here? What's their main concern or their main problem? Now, I may also briefly clarify, is this a recent thing, a recent problem, or is it something ongoing? But I'm not going to stop and take a full history. I'm just going to clarify the time frame. And then I need to clarify, if they have more than one problem or concern, which is the main one, because sometimes we need to focus our examination on the main one as sort of a time management. And then lastly, setting the scene. And this is trying to put the patient at ease by helping them understand what's going to happen today. So particularly, as I said earlier, if they haven't seen a physiotherapist before, they could be quite anxious about what's going to occur. They don't know how long they're going to be there. They maybe are unsure as to whether they have to take any clothes off. So the sort of things that we will incorporate in this setting the scene is what we're going to be doing. So today we'll be doing an examination. It'll typically take us about this long. I'll be asking you lots of questions about your problem. For example, your description of it and where you feel it. I'll also be asking you lots of questions about how it's affecting you. That is, what you can do and what you can't do. And then we'll go into what we call the physical examination, where I'll be specifically testing different body areas associated with your problem to understand if there's any physical impairments or problems associated with the problem. And then at the end, I'm going to give you a summary of my analysis. It's really important the patient knows that's going to be part of the whole process, that I'll give you a summary of what I think is going on and what is my recommendation for management. Thank you.